immunodeficiency diseases, specific diagnostic tests, and approach to patient with primary immunodeficiency diseases. Again, I would like to start with this slide, and there are a few patients with different manifestations. Top left is a patient with some respiratory tract infections and GI problems. Top middle is a patient with impaired wound healing. The third one is a patient with atoxic gait and telangiectasia. The next one is a case with ophthalitis, abscesses, lymphadenopathy. The next one is the case with oculocutaneous hyperpigmentation or albinism, and the last one is a patient who was complicated with disseminated BCG after BCG vaccine. Yes, please.
Is there any proper treatment of allergy?
What?
Is there any proper treatment of allergy?
This one?
No, is there any proper treatment of allergy?
Is there any
treatment? Proper treatment?
Yes, I will discuss about the treatment of the allergic disease and physiopathology. So when you come to Tehran, I have again classes with you. I mean, when you pass the Ulumpaye. So I will discuss about the treatment of allergic diseases, treatment of the primary deficiency, but this is the basic immunology, so I'll just discuss about pathophysiology and the main manifestation. Okay, so if you remember from the previous class, I mentioned that immunodeficiency could be classified to primary and secondary, and there are more than 400 types of primary immunodeficiency diseases. Primary immunodeficiency diseases are an heterogeneous group of disorders. What does it mean? Heterogeneous.
Very different.
So on one side, we have a disease, there is a disease with the name of selective IgA deficiency. It means that the IgA is low, but IgM, IgG, the remaining are perfect, without any problem. IgA is located in the mucosal line, so the patient with IgA deficiency should suffer from sinusitis, otitis media, pneumonia, and diarrhea, okay, because it's located in the mucosal line of the respiratory tract and gastrointestinal tract. And on another side, there is a disease, it's very common, selective IgA deficiency. 1 per 700 individual has selective IgA deficiency, and sometimes the people do not know about the disease because they are suffering from sinusitis, otitis media, and do not check the immune system. So it's very common. In another side, there is another disease with the name of severe combined immunodeficiency. The patient has no T cell. The patients cannot see their first birthday because they have no T cell and they die. So it's very severe. So it's a heterogeneous from selective IgA deficiency to severe combined deficiency, and there are more than 400 diseases between these two diseases. So a gene defect leads to defects in the immune system and leads to infection, autoimmunity, and malignancy. So they are the main manifestations of the patient with primary immunodeficiency diseases. So the patient should suffer from increased susceptibility to infection, autoimmunity, and cancer. There are 10 warning signs to be aware about primary immunodeficiency diseases. I should mention that the rate of primary immunodeficiency diseases are quite high, but underestimated. For example, today afternoon, I'm planning to go to the clinic and see the patient in Kish Island who are suffering from infectious diseases. So we had a congress last week, and there are a few physicians from Kish Island who came to the congress and invited me to go to the clinic and check the immune system. And I'm sure that in Pakistan, in India, in Iraq, there should be many patients, and there is no physician to diagnose them. Only in India there is a city, Chandigarh, PGMI, very well developed hospital, and there is a Dr. Surjit Singh, I think the name is Suresh Singh. And he's very well known about the immunodeficiency. But the rest of India has no idea. Pakistan has no idea. We have no data about primary immunodeficiency disease in Iran, in different countries. But I established a registry of primary immunodeficiency diseases in Iran more than 20 years ago. And now we have a registry. more than 5,000 patients have been registered in our registry. So there is a need. I mean, you should go to your countries and educate the people about primary deficiency disease. And it's not very complicated. There are 10 warning signs. The first one, increased susceptibility to infection. What does it mean?
You are prone to get
Four or more than 4 times otitis media per year. 2 or more than 2 times sinusitis per year. 2 or more than 2 times pneumonia per year. 2 or more than 2 times any serious infections per year. It shows that the patient might have immunodeficiencies. So we should have suspicions about immunodeficiency. The second one, increased severity of common infection. So, I mean, the common cold is not immunodeficiency, but if a patient goes to the hospital, admitted, get antibiotics, and takes time to be treated, so we should think about the immunodeficiency. The third one, infection with unusual organism, monocystis etiology, aspergillus, nocardia, serratia. Why a healthy human should suffer from such unusual infection? We should think about immunodeficiency. FPT, the children that cannot grow well despite good nutrition. So we should think about immunodeficiency. Unusual response to vaccination. All the kids receive, some vaccination like OPV, polio vaccine, and then some of them get poliomyelitis, or get Rezaie vaccine and it get to lymphadenopathy, Rezaiitis. So it's a sign of the immunodeficiency. Unresponsive to the oral antibiotics and need for IV antibiotics, intravenous antibiotics. It's again a sign of the immunodeficiency. Some autoimmune and autoinflammatory syndrome. There is a big group of disorder with autoinflammation, like FMF, familial Mediterranean fever. They usually suffer from abdominal pain, periodic fever, periodic abdominal pain, rashes. So this is a group of disorder. Characteristic combination of clinical feature like syndrome. What is syndrome?
Group of symptoms.
In different organs. Can you mention an example of primary deficiency syndrome? Have you heard about Dye-George syndrome? Dye-George. So it's a combination. They have agenesia of thymus, no T cell. They have hypocalcemia, hypopara, cleft palate, some problems in the the septum, axial septum. So you can see different organs. So this is a syndrome. Angioedema. Do you remember which disease leads to angioedema? Congenital angioedema? Maybe Dr. Isaac mentioned it in the complement session. C1 inhibitor deficiency. C1 inhibitor deficiency leads to congenital inherited angioedema. And last but not the least, family history of recurrent infection, which is very important in our region. Why it's important? Why family history of death or recurrent infection is important in our region?
Like marriages among cousins.
Exactly, because of high rate of consanguinity. Do you know the rate of consanguinity in your countries? The rate of consanguinity, related marriages. No idea? 2%, 5%, 10%, 20%. No idea? It's about 30 to 50%. Okay, and it increased the rate of autosomal recessive disorder because the mother and father have carrier for a mutation, and 1/4 of the children are going to have the autosomal recessive disease. And sometimes the high consanguinity, for example, a patient from India, from Ahmedabad, come to clinic and say we have no relation with each other. And then the father is from Ahmedabad Sofla and the mother is from Ahmedabad Ulia. So they are from the same ancestor and came to two sides of a river and make a colony. So the mutation, went to the next generation. Okay, so we should be very careful about the high rate of consanguinity or related marriages in our region and increase the rate of autosomal recessive disorders. So if you remember the immune system classically could be classified to the innate immunity and adaptive immunity. Each part would have a cellular and humoral part. What is the cellular part of innate immunity? Neutrophil, okay? Neutrophil, phagocyte cells. What about the humoral part of innate immunity?
B cell.
Innate immunity.
Oh, innate.
Humoral.
NK cell.
Humoral.
Immuno.
Complement. What about adaptive, the cellular part? T cells.
T cell.
What about the humoral part?
B cells.
B cells and antibodies. Okay? So I would like to discuss about the phagocyte defect, complement deficiency, T cell defect, and antibody deficiency. Regarding complement deficiency, there is a little bit that has been mentioned in your book, so I'm not planning to discuss more. But if you remember the complement cascade, at the end there was C5 to C9, where we mentioned MAC. Okay? So when we have defects in the MAC, it leads to Neisseria infection. Okay? And the patient with complement deficiency are predisposed to autoimmune disorders as well. So phagocyte defect. There are a few diseases. The first one is chronic granulomatous disease, CGD. What does it mean? Please imagine that a pathogen come here, this is our body, and I'm planning to get the pathogen and digest it. And I cannot digest it. So there is a functional defect in the phagocyte. So I will ask all of you to help me. Please come and help me. So we make a granulome. Okay, this is chronic granulomatous disease. It means that the pathogen come inside, I can get the pathogen, but I cannot digest it. So I ask all the immune cells to help me and then make a granulome. This is chronic granulomatous disease. The mutation in phagocyte oxidase leads to CGD, and there is a failure to kill the phagocytose microbes. And the patient usually suffers from infections with fungi and intracellular bacteria. It seems that interferon gamma increases transcription of the FOX91 gene and stimulates production of superoxide anions. So it could be used as one of the treatments for CGD. The second disease is leukocyte antigen deficiency. Please imagine that there are enough leukocytes in the circulation, but the leukocyte needs beta-2 integrin to move in the circulation. So if there is a beta-2 integrin defects, the leukocyte cannot move in the circulation. So if I have a lesion in my skin, what will happen?
It cannot reach there.
It cannot be healed. Okay? So they have impaired wound healing. So the leukocyte cannot move in the circulation. Impaired wound healing. One of the first signs of the patient with leukocyte antigen deficiency is impaired in detachment of umbilical cord. So do you know that what time the umbilical cord should be detached? After birth. 10 days to maximum 2 weeks. Okay? So the mother brings the child to the clinic at the age of 1 month that the umbilical cord has not been detached, and we need surgery. Why? Because the leukocyte cannot move to the stem of the umbilical cord and make detachment. Okay? So they suffer from umbilical cord delay, umbilical cord detachment, impaired wound healing, and all the phagocyte defect. I usually warn the parents about the oral cavity and anus region, because this is full of the pathogen. and the phagocyte system cannot, work well. So there are periodontitis, the dental erosion, some oral and anal abscess lesions. So we should be very careful about these two lesions. So LAD type 1, the defect is based on beta-2 integrin, and CD18 and CD11 is responsible, we should detect these ones as defects of the LAD type 1. But in LAD type 2, the defect is not based on integrin. It's based on the absence of the CRE6. And we usually check CD15. So CD18 and 11 for LAD type 1, and CD15 for LAD type 2. The next disease is Chediak-Higashi syndrome. The patients usually suffer from oculocutaneous hypopigmentation or albinism. So if a patient with infection and albinism refer to your clinic, you should think about oculocutaneous hypopigmentation, and the name of disease is Chediak-Higashi syndrome. If we check the peripheral blood SME, we usually find some giant granule in the lysosome, in the leukocyte. And the last group of innate immunity defect is defects of toll-like receptor. Do you know what's toll-like receptor? What is toll-like receptor? Receptors of? No. Receptors of innate immunity, like macrophage. Okay? They are for detection of PAN, pathogen associated. Okay? So this, and just a decade ago, the Nobel Prize for detection, discovery of toll-like receptor went to the Jules Hoffman because they detected the toll-like receptor. So one of the diseases in toll-like receptor deficiency is anhidrotic ectodermal dysplasia with immunodeficiency. What is ectodermal dysplasia? Like cuneiform teeth, defects in the skin, hair. This is ectodermal dysplasia. What is anhidrotic? This is hydration and no hydration. They have no sweat glands. Okay? So they bring the child to the clinic just with a nappy, without any clothes, because they cannot sweat. They are very hot. They have eczema. They have, when they cry, you can see that they have cuneiform teeth. Okay? And this is anhidrotic ectodermal dysplasia with immunodeficiency, and the defects is based on Nimo, in NF-kappa essential modulator, Nimo, N-E-M-O. This is a mutation of the anhidrotic ectodermal dysplasia with immunodeficiency. Okay, please let me know what I mentioned in this class. Please mention the name of diseases that I mentioned so far. Leukocyte antigen deficiency. So leukocyte antigen deficiency in type 1, if I plan to detect, to make a diagnosis, what should I do? CD18 and CD11. There is another test for detection of the LAD, which is chemotaxis test. Chemotaxis check the movement of the leukocyte. So chemotaxis test, CD18 and CD11 for detection of the LAD type 1. And we have LAD type 2 as well, which is CD15.
15
and
or 11?
Focus transporter gene, CRE6, not integrin. Okay? So what else?
Which gene? We check in the LAD type 2?
Focus transporter gene in LAD type 2. Yeah. Okay. So one disease is LAD. Another one. Chediak-Higashi syndrome. What's the main phenotype of Chediak-Higashi syndrome? Albinism, oculocutaneous hypopigmentation. And if we check the peripheral blood SME, we find giant granules. Okay. What else?
Toll-like
Exactly. Toll-like receptor defect, like Anhydrotic ectodermal dysplasia with immunodeficiency. The gene defect is Nimo. And NF-kappa B essential modulator. What else? What did I show you here?
Granulomatous.
CGD, chronic granulomatous disease. Okay? So to make the diagnosis of CGD, we usually have two tests. The first one is NBT, nitroglutathione test, NBT. This is a slide, and it should change the color from pink to blue. So nitroglutathione test. And the second test is DHR, dihydrorhodamine test, DHR. So there are two tests to make the diagnosis of CGD. Okay, what else? Complement deficiency. Okay, and I mentioned that in C5 to C9, if we have defect of the C5 to C9, it leads to Neisseria infection. And there is another complement deficiency which leads to angioedema, C1 inhibitor deficiency. Thank you. Okay, let's move forward. I completed the innate immunity. Now I'm planning to move for the adaptive immunity. I need your help. Please have a look at this diagram. Especially Fariha. I would like to ask this question from Fariha. Fariha Mahdi. Because you are always in your mobile phone from the beginning, so I would like to ask a question from you. Okay? No. Please just have a look at this diagram. You can answer. Please imagine that this is the hematopoietic stem cell.
Click pointers.
Okay, this is hematopoietic stem cell. It goes to pro T cell, then pre T cell, and then T cell in circulation. Is it clear? In that side, it goes to the pro B cell, pre B cell, and B cell in circulation. Was it clear? Okay, my question. If there is a patient with mutation in gamma chain here, can you see gamma chain? What's the result? Do you expect T cell? What about B cell?
Because if the mutation is in CIP, that's helping pro-B as well as protein. So I don't think it will.
Where is it? This is B cell. Can you see gamma chain here?
No, only it will affect T cell.
Only T cell.
Yeah.
Okay? So it leads to T minus, B positive, a ski. What is a ski? Severe combined immunodeficiency. A ski, severe combined immunodeficiency. Which type of a ski? T minus, B positive. Is it clear?
Yes.
Okay? Okay, the second question. From Nazar Saman. Okay? The second question. Please imagine that there is a mutation in adenosine deaminase or polynucleotide phosphatase, ADA or PMP. What's the result?
It only affects the T cells.
Are you sure?
Both.
It affects T cells and also B cells.
Exactly, because it's here as well. So not only T cell and B cell, but also NK cell. So this is T minus, B minus, NK minus, a ski. This is a ski that has no immune cells. Was it clear? The third question from you. Please imagine that there is a patient with LAG1, LAG2 mutation. because like 1 and like 2 are both, okay? So again, this is T minus, B minus, but NK is positive, ST, okay? T minus, B minus, NK positive. And the last question, I need a brave guy or lady to answer because it's very difficult. Who is volunteer to answer? You? Okay. Please imagine that there is a mutation in BTK, boloton tyrosine kinase. BTK.
Obviously, we have issue in B cells firstly.
Okay, so this is T positive,
B negative.
minus escape.
Yes, sir, I get it.
So was it difficult?
No, sir.
So why I mentioned that this is difficult and I need a very blind.
That's why I am very. That's why I'm thinking.
What's the problem?
Problem. Psychological problem.
Psychological problem. I mentioned that in a SCID patient, they should have no T cells. Okay? But this patient has T cells, so it's not a SCID. It's true, this is T positive, B negative, but it's not a SCID. It's antibody deficiency. The name of disease is X-linked A-gamma globulinemia, Bolton disease. It's not a SCID. In the previous cases, it was a SCID because they have no T cells. But in this case, it has T cells. Okay. So please have a look at this table. So it's very difficult. So I mean, none of you will pay attention to this table because it's not worth to remember. But it's very simple. This is what I mentioned. Please have a look here. So I would like to ask a question from this in your exam. Okay? So for the rest of people who did not attend, it's very difficult to answer. But for you, it's very easy. Why? Because the first group, effects in cytokine signaling. You can see like gamma chain. Okay? What was the result of gamma chain?
T negative, T positive.
You answer. Okay? This one. Where is that one? You answer. T minus, B positive. Please have a look at this table. They have marked decreased T cell, normal or increased B cell. Okay? This is the first group. Have a look at the second group, ADA or PNP. Defects in non-protein established pathway, ADA or PNP. What was the result? No T, no B, no NK. Am I right?
Yes,
So please have a look. Progressive decrease in T, B, and NK. Is it difficult? The third group, VDG recombination. You answer about the lag 1 and lag 2. What was the result? T minus, B minus. Please have a look. Decreased T and B. Was it difficult?
No.
So if I ask you a question from this table, you could easily answer. Because I mentioned, if you have a look at this diagram, you can easily understand what's inside the table. There is no need to memorize everything. You should just have some keys about the tables and the figures. Okay. So I mentioned about ST. Let's move forward with Bolton disease. Okay, I mentioned that this is a low B cell count. This is a defect of parent B cell receptor signaling. Yes, please.
Does that mean if we have any cytokine signaling issue in gamma interferon, that always leads to SCID T negative, B positive?
Yes.
Always.
Always. Yes.
If we have salvage, then B
Yes.
negative.
Yes. But when I mention T minus, it doesn't mean 0. It means lower, less than low. Okay? For example, when I mention Bolton disease, it's less than 2% B cell. It doesn't mean 0 B cell. Okay? So in BTK mutation. So you answered about this disease. So when I mentioned that, what is X-linked A-gamma globulinemia? If you have a look here, again, BTK. This is peri-B cell receptor, just before the peri-B cell. This is BTK. So This is B-cell receptor signaling defect because of Bolton disease, and they have no B cells, but T cell is intact, NK cell is intact. And all the patients with Bolton disease, SC, they should have low immunoglobulin level as well. Okay? So they need B cells to produce antibodies. So they have all low immunoglobulin level. So for the patient with Bolton disease, we name X-linked A-gamma globulinemia. Gamma globulin, A-gamma globulinemia. It means no gamma globulin. Okay? And it's X-linked pattern. They have low B cell numbers. You can see less than 2%. Another disease of antibody deficiency is selective immunoglobulin isotype deficiency, like selective IgA deficiency. Do you remember from the beginning of the first class, I mentioned about selective IgA deficiency, and it's about the mucosal line. So some of the patients might be asymptomatic, without symptoms, or have mild phenotype, just sinusitis, otitis media, and it's very common. This is the most common form of disease, 1 per 700 individuals. Another disorder is common variable immunodeficiency, or CVID. Please do not confuse CVID with SCID. SCID is severe combined immunodeficiency. This is T cell, but CVID is common variable immunodeficiency. This is antibody deficiency. It's about the plasma cell. They cannot, I mean, the difference between XLA and CVID. In XLA, we have no B cells, but in CVID, we have B cells, but they cannot produce antibody. They cannot move to plasma cells, okay? And the last group of disease in antibody deficiency is hyper-IgM syndrome. The term is not, I mean, very accurate because the name should be changed to immunoglobulin class switch recombination deficiency. We need class switching from IgM to IgG and IgA. If we have the defect in immunoglobulin class switch recombination, IgG and IgA should be low, but IgM should be high. That's why we mentioned hyper-IgM syndrome. Okay? So what I mentioned in antibody deficiency is...
Can you please repeat this point?
Sorry?
Can you please repeat this point again? Hyper-IgM syndrome.
Repeat it?
Yeah.
In hyper-IgM syndrome, the defects is T cell dependent B cell activation, and the mechanism is class switch combination defects. So IgM cannot class switch to IgG and IgA. Okay, so IgM remains and increased, but IgG and IgA are low. Was it clear?
Yes.
Let's write something here to make it more clear for you. SE, CVID, XLA, hyper-IgM, and selective IgA deficiency. Okay? This is T cell defect. These are antibody defect. Okay? This is T. These are. Okay? So please let me know. SE patient, do they have T cells?
No.
Okay. What about B?
Yes.
May or may not be.
Yeah.
Yes or no? Yes in what? Gamma chain. No in what? ADAPMP. Like 1, like 2. Okay? Could be positive or negative. IgG, no. IgN, no. IgA, no. Okay? I mentioned that in SQ we have hypogamma. What about CVID? Do we have T cell?
Yes, sir.
Yes, because it's antibody. No T cell. Okay, so we have T cell. B cell.
Yes, we have,
Yes.
but it
Yes,
does not.
but-
IgG, IgM, IgG plus. We do not have plasma cell. What about XLA? Do we have T cell?
Yes, sir, we have.
Yes.
Yes.
B cell.
No.
No.
Okay, this is the difference between XLA and CVAD. In XLA we do not have T cell, but in CVAD we have T cell. So IgG, IgM, IgA. What about hyper IgM?
IgM.
Yeah.
Do we have T cell?
Yes.
Yes, sir.
B cell?
Yes.
IgG?
Yes.
IgG?
No.
No.
IgM?
Yes.
Yes, sir.
Yes. IgA?
No.
Is it clear?
Yes, sir.
Selective IgA deficiency. We have T cell?
Yes, sir.
Selective IgA deficiency. What does it mean? It means that we have only IgA deficiency. So we have T cell, we have B cell, we have IgG, we have IgM. Selective IgA deficiency. We have only defects in IgA. I know that, immunodeficiency is very difficult, okay? But I'm doing my best to make it simple. You should know this one, okay? This is the difference between different diseases.
Sir, in the natural antibody of any B cell, natural B cell, etc., or any cells,
What?
natural antibody that produced by a B cell is IgM, right?
Yes.
It should switch to any other IgG.
Yes,
According to antigen.
Yes.
Right?
Yes. Okay. So in addition to, it was about the antibody deficiency, this one. And this is about the T cell. In addition to SP, we have some other diseases in T cell defect, like effects of MHC. So did you remember about MHC, MHC class 1 and
Yes,
MHC
sir,
class
yes,
2? When I was a medical student, I just memorized that MHC class 1 is related to CD8 and MHC class 2 is related to CD4. Okay? CD4 with MHC class 2,
Yes.
MHC class 1 with
CD8.
CD8. Okay? So if a patient has MHC class 1 deficiency, it means that CD8 should be low and HLA, BP, DQDR cannot be expressed. Am I right?
Reverse.
No, sir.
Like, it can be expressed.
MHC class 1.
Class 1.
We have defects of MHC class 1. CD8 should be low, okay? And HLA, DP, DQDR cannot be expressed. What is MHC class 1?
All nucleated cells.
MHC class 1 is HLA A, B, C. MHC class 2 is DP, DQDR.
Yes.
So if we have defects of MHC class 1, CD8 is low, but HLA A, B, C cannot be expressed. But if we have defects of MHC class 2, CD4 is low, HLA, DP, DQDR cannot be expressed. Okay? Is it clear? Okay. There is another disorder with the name of Wiskott-Aldrich syndrome. We have another disease in innate immunity. The name was Chediak-Higashi. What was the sign of Chediak-Higashi? Albinism. Okay? So Wiskott-Aldrich syndrome is another syndrome. It's extinct. They have period of eczema, thrombocytopenia, and infection. They have local antler, and they have bleeding, eczema, and otitis media. So this is Wiskott-Aldrich syndrome. Do you remember from the previous class about the thrombocytopenia? We have a hypersensitivity disorder with thrombocytopenia. What was the name? In first class.
Type 2.
What was the name? Autoimmune thrombocytopenia purpura, ITP. And what was the mechanism? Type 2. The mechanism? Opsonization and phagocytosis. Okay, it's not I mean related to viscotaldehyde, but if a patient with thrombocytopenia come to my clinic, I think about either autoimmune thrombocytopenia purpura, which is a hypersensitivity, or viscotaldehyde syndrome, and it should be boy, because this is X-linked. If a boy comes to my clinic with thrombocytopenia, I'm expecting viscotaldehyde syndrome. But if a girl comes to my clinic, it might be autoimmune thrombocytopenia purpura. Okay? Did you get the point? Because viscotaldehyde syndrome is extinct. So we can see this one in only boys. Okay? In a male. Okay. In addition to the diseases that I mentioned here, there are some multi-system disorders like ataxic telangiectasia. They have ataxic gait. They cannot have equilibrium. So they have ataxic gait and they have telangiectasia, the ocular bulb. The name of this is ataxia telangiectasia. So the problem is in cerebellum. This is double slant DNA syndrome, and they are predisposing to cancer, and IgA and IgG2 is usually low. Okay. So until now, I mentioned about primary deficiency diseases. I explained a few of common disorders. I didn't explain all 400. I just selected the most common ones and explained about the diseases. Now, we would like to go to the clinic. When a patient comes to the clinic, first we should review the medical history. This is the first step. We will ask a few questions from the patient. If a patient has a current pneumopulmonary infection with encapsulated bacteria, we usually expect humoral deficiency. When I mention humoral deficiency, it means either antibody or complement. And if we expect antibody deficiency, we could think about this one. CVID, XLA, ST. Can you see? This is antibody deficiency, low antibody level. If a patient has opportunistic infection with pneumocystis jirovecii, we should think about T-cell defects. Do you know any disease with low T-cell number? SCID, severe combined immunodeficiency. And it could be due to function of the immune system, like CD40 ligand deficiency in hyper-IgM syndrome. It could also be happening. If a patient comes with abscesses in different organs, we should think about phagocyte defect. So we might think about CGD. So if they have suspicious to CGD, what should we do? What test? Do you remember?
Which test?
For CGD.
NBT.
NBT or DHR. If we have suspicious to LAD, NBT and DHR for CGD. What about LAD? We could do chemotaxis test, CD8, CD11. Okay, thank you. If a patient comes to the clinic with delayed separation of umbilical cord, periodontitis, omphalitis, what's the disease? Delayed in detachment of umbilical cord, impaired wound healing. This is excellent. What's the name of disease? Lab type 1. So what is lab? Abbreviation of what? Leukocyte adhesion deficiency. If a patient comes to the clinic with some associated problems like congenital heart defect, hypocalcemia, and absence of thymus, it's not difficult. You could read almost. There's Dyer's syndrome. If a patient comes with abnormal gait and telangiectasia, what is it? Ataxia telangiectasia. If a patient comes with eczema, petechia, bleeding disorders, and thrombocytopenia, what is worse? Was or where? Viscotaldehyde syndrome. and a patient with angioneuritic edema, C1 inhibitor deficiency. Okay, so the patients come to the clinic, I ask a few questions, and I am suspicious about the primary deficiency disease. Now I would like to order a few laboratory tests. So the first screening test is CBC, complete blood cell count. It's very easy, simple, cheap, and available everywhere. Okay, so you could easily check CBC. In CBC, if you find leukopenia, lymphopenia, we could think about the first one, a SCID, because the patient has T-cell defects and the total number of lymphocytes is getting low. If the patient has leukocytosis, very high number of leukocytes, we could think about LAD if we exclude lymphoma, leukemia, okay? If we exclude, we should think about leukocytosis. Why? Because the leukocyte cannot move in the circulation. So make order to bone marrow to make more leukocyte. Again, leukocyte come and cannot move. So leukocytosis. If the patient has thrombocytopenia, in CBC. No platelet count. You check the CBC and found that the patient has thrombocytopenia.
Very Escort syndrome or 5 to 5%. That syndrome which you told weaker.
Viscott-Aldrich syndrome could be the diagnosis. Okay. So CBC, culture, and radiography are some screening tests which help us to make a diagnosis. And then move forward with sophisticated tests. For antibody-mediated immunity, we usually check IgG, IgM, IgA, IgE. We could check isohemagglutinin titer. What is isohemagglutinin?
What's that?
Isohemagglutinin titer. Is based on immunoglobulin level. You all know that we have blood group A, B, and C. Okay? We have blood group A, B, and C. Are you sure?
No.
Why do you do not have blood group C? Okay. So I have blood group A. What should I have? Anti-B. If I do not have anti-B, it means that I have defects in production of antibody. So we could check isohemagglutinin titer. So if I have blood group A, I can check if I have anti-B or not. If I do not have anti-B, it means that I have immunodeficiency. Okay? We could check some specific antibody titers against some vaccine, and we could measure the B cell number by CD or DVD. When we plan to check the, the class of differentiation of the B cell, do you check CD19 or DVD19? CD19. Okay, CD19, CD20, CD21 are the markers of the B cell. What about the T cells? There are CD3 positives, either CD4 or CD8. They are the markers of the T cells, and we could check delayed type hypersensitivity. I mentioned in the last class. So we could make subcutaneous antigen and check 24, 48 hours later, like PPD, okay, to check the function of the T cells. Was it clear? So we could check the quantity of the T cells by measurement of the CD3, CD4, CD8. But the quality of the T cells, by delayed type hypersensitive, to check that if it's reactive to the antigen or not. Okay? And for phagocytosis, we could check NBT or DHR. NBT, and DHR. For which disease? CGD. We could check chemotaxis test. For which disease?
Granulomatosis.
Lag. Okay. And for complement deficiency, we could check CH50 to check the classical pathway of the complement, and AP50 for the alternative pathway. We could measure each level of complement, and C1 inhibitor function and quantity could be measured. Okay. Let's get back to this slide. Now it's your turn to answer my question. Are you ready? The first case is a 6-year-old boy who was referred to our center with chest pain, recurrent pneumopulmonary infection with encapsulated bacteria. He was well until the age of 6 months. Why he was well until the age of 6 months? Why he was well until the age of 6 months?
Because he gets the antibodies from the mother.
Exactly, from the mother, okay?
Yes.
Then he was hospitalized because of pneumonia. He had history of recurrent otitis media, leads to perforation of left tympanic membrane, and the patient has no tonsil, no adenopathy, and you can see that the patient has lobar pneumonia. Okay, this is a chest X-ray. This is right lung and this is left lung. This is heart and this is diaphragm. You can see that there is opacity here. Can you see? It means that there is a lobar pneumonia in the right lung. It should be like this one, clear, but it's not clear. There is opacity. This is lobar pneumonia. And the patient has no tonsil. Okay? We checked the immunoglobulin level and we found that the patient has low IgG, low IgA, and low IgM. To make the diagnosis, which of the following approach could help us? B-cell, T-cell enumeration, NBT, delayed type hypersensitivity, or complement test? Which one? Which one? So why did you have a look here? If you plan to do MBT, why did you have a look at this table? The patient has hypogamma, okay? The patient has hypogamma. Low IgG, low IgM, low IgA, okay? Okay? So I would like to make a diagnosis. What should I do? I should go and check T-cell and B-cell. Am I right?
Yes.
I know that the patient has IgG, IgM, IgA low. So what's the next step? I would like to show that it is SCID, CBI, or XLA. So I should check the B-cell, T-cell.
Yes.
Am I right?
Exactly.
So I checked the B-cell and T-cell, and I found that the patient has normal T cells, but the number of B cells is very low. Can you see? It's 1%. So what's the diagnosis?
Excellent.
Who agree with CVID? Who agree with hyper-IgM? XLA? XLA? If I have a look here, you can see that all the people. Okay, XLA?
Yes, sir.
The patient has low IgG, low IgM, low IgA, and low B cell. But T cell is normal. So what's the diagnosis? So what was the genetic defect?
In XLA?
You were the brave man.
BTK.
BTK, exactly. Both on. Okay, we check And we found that the patient has BTK deficiency. The diagnosis is accelerated. Who is absent in this class that he was present in the last class? Good. The second case is a boy who was referred to our center with lymphadenopathy, omphalitis, and he had history of deep-seated abscesses due to Staphylococcus and aspergillosis. His family histories showed that the maternal uncle died because of Aspergillus pneumonia at the age of 14. We checked the laboratory tests and we found that the patient has normal immunoglobulin level and HIV was also negative. To make the diagnosis, which laboratory test should be performed? Which one? The patient has abscesses, lymphadenopathy, and immunoglobulin level was normal. So we would like to make a diagnosis. What should we do? Exactly. MBT. Okay, we perform MBT and MBT was defective. What is the diagnosis?
C. B.
Okay, CGD, chronic
granulomatous.
because we perform MBT and MBT is defective. And this is the extreme form because I mentioned that the patient maternal uncle died. So this is the extreme form of CGD. Case number 3. A boy who was from consanguineous parent, oculocutaneous hypopigmentation, otitis media, mental retardation. What is the most likely diagnosis? What is the diagnosis? Celiac Higashi syndrome. So how we could make the diagnosis? What was the pathognomy?
Albinism.
Albinism, and what should we do in the laboratory? Giant granule.
Yes.
So if we check, you can see that they are giant granule, giant cytoplasmic granule. And if we put the hair of the patient under microscope, we cannot see melanin in the middle of the hair shaft. Okay? In the middle you should see the melanin, but there is nothing there. Case number 4. A boy who was admitted to a hospital with impaired wound healing. He had history of delayed separation of the umbilical cord, omphalitis, and he suffered from periodontal disease and abscess. What is the most likely diagnosis? So what should I do to make diagnosis?
Hemotaxis
and
CD11.
CD18 and CD11. And if you have a look here, you can see that leukocyte count is 53,000 leukocytosis. Can you see? High leukocyte count. And no expression of CD18. Okay? Case number 5, it's not my patient, so I had a few patients, but I didn't got any picture from them. So, I mean, the previous patient was from my clinic, but case 5 is from one of my colleagues at home. A 9-month-old infant who was referred to the hospital with mild developmental retardation, cleft palate, mild congenital axial septal defect, otitis media, and hypocalcemia. Diagnosed syndrome, and the patient has agenesia of thymus. Case number 6 is very difficult. Please be careful about it. A girl who was referred to our center with ataxic gait and telangiectasia. So what is the diagnosis?
Ataxia, telangiectasia.
The patient with ataxic gait and telangiectasia. What is the diagnosis?
Mostly.
Ataxic telangiectasia. So it's signal. It's not. This time it was signal. Okay. And the last case, which is also important, a 6-month-old infant who was referred to our hospital with lymphadenitis, oral candidiasis, osteolytic lesion, respiratory distress, hepatomegalia. The parents were consanguine, and the first child of the family died because of disseminated vesicles at the age of 7 months. So which laboratory test should be performed for this case?
So BCG stands for? What does BCG stand for?
What?
Abbreviation.
BCG.
Bacillus calmette vaccine. Vaccine for tuberculosis.
TB.
Vaccine.
Yes.
Which test? What is the first screening test? The first screening test? CBC. CBC is the first screening test. What next? Checking the immunoglobulin level. So you can see that the patient has quite lymphopenia. IgG is low, IgM is low, IgA is low. What about the B cell number?
B cell is also
Normal.
low. B cell is
B cell is 2%, the normal is 9 to 38.
Low.
Is it high, low, or normal?
Low.
Okay, thank you. What about the T cell?
Low.
Low. What about the NK cell?
And
much more.
Much more. So what is the diagnosis? SCID, severe combined. Which type of SCID?
Gamma. Right.
T minus, B minus, NK positive ST. Okay, so the patient has disseminated vesicles, hypogamma, decreased B cell and T cell. So T minus, B minus, NK positive. So what's the genetic defect? Exactly what you mentioned, LAC1 and LAC2. So if you have a look here, you can see T minus, B minus, NK positive, and we detected LAC2 mutation. And why I mentioned the case here, it's very simple, but this is a real case. The first child of the family died because of a skip patient. So, I mean, a private lab mentioned that we can do perinatal diagnosis at the age of 10 to 12 months. We could get the PND and the perinatal diagnosis. And they just opened the book and checked gamma chain, which was not true. And they mentioned to the family that your child will not have a skip. The second child was born, get vesicles, disseminated vesicles, and this case was also died. This is a disaster. If we have no knowledge, we should mention that we do not have any idea. The patient was T minus, B minus. Why did they check gamma chain? Gamma chain is responsible for T minus, B positive. It's very simple from the basic immunology. Okay? So the patient has, fortunately the family has a new baby and the child is healthy without any problem.
I'm saying why not ADA, PNP deficiency?
Because the ADA and PNP is here. T minus, B minus, NK minus.
NK minus. Okay.
Okay?
Alright,
But the patient NK was
much more.
okay. Okay, so what I mentioned is again from the textbook of the Abolab boss, and I asked my question from what I mentioned here. For those who are interested in the field of primary deficiency diseases, this is the textbook of primary deficiency diseases. For those who are, the pediatric immunology and allergy fellowship in the United States, in Europe, in Australia, this is the textbook reference book. And I will, this is the second edition, and the third edition will come in 2024. I should mention a story which is interesting for you. I edited the first edition in 2008 with 200 diseases, okay? The second edition with 350 diseases in 2016, 8 years later. And now, in 2024, the next edition will come with more than 500 diseases. It means that the number of primary immunodeficiency diseases has been increased more than twice in 1 decade. So it shows that how much the physician should be updated ourselves, regularly. One of my main jobs, every Saturday, I will go to the PubMed and search primary immunodeficiency diseases, not HIV, to see which paper has been published during last week. There is a need to be updated. And if we do not, open the book, do not read the paper, we get, just a year later, we have no idea about the new diseases. So I would like to highlight this point that how much is important to be updated. Thank you for that.